It is so disheartening when an 80-year-old cries saying, I have to drive 35 miles to get my medicine because my payer will not allow me to get it here. Healthcare is about individuals. There are not enough algorithms for every individual.
Hello, welcome to the Litson Podcast Room, home of the RxLaw Group. Honored today to be joined by Dr. Marty Blane. Dr. Blane, let me make sure I have all the titles correct. Professor, pharmacist, board member. Am I missing anything else?
Attorney.
Attorney and city judge, right?
City judge, yes.
City judge.
Mm-hmm.
How long have you been city judge?
This is the 23rd year.
23rd year of Dover?
Of Dover.
Okay. So you are from?
From Dover.
Yep.
Born and raised in Dover, Tennessee. Only moved away pretty much for school and then returned to my hometown, my home community after school.
And serve in all of those ways. That's truly, truly remarkable. So, pharmacist first?
Pharmacist first. Yes. Growing up, you always are thinking about what do I want to be, and in my family, college was not optional. You were definitely going, and so it was like job shadowing was not as prominent, so I was thinking doctor, lawyer, teacher. I really wanted to be a teacher. Some of my teachers dissuaded me from that profession. So healthcare was the area I was most interested in, and I wasn't sure what role. So I started college just under kind of a pre-health curriculum and was speaking with some other students, and they were talking about pharmacy, and sounded great to me. And so that is the area that I pursued. Pharmacist first. Been doing that for 36 years.
My goodness. What was the timeline to then obtain the law degree?
So during pharmacy school, I really was interested in pharmacy law, the pharmacy law course. And I've always been interested in the law and how it works, fascinated by it. So I got out of school, needed to get a job and earn some money. And I kept thinking, I really think I might want to go back to law school. So finally, 5 years in, after practicing pharmacy for 5 years, I decided that it was now or never. I needed to do that before I got any more settled. So it was 5 years of pharmacy practice before I returned to law school.
And we're going to get to pharmacy deserts in a little bit, but I want to tip this off now. How many pharmacies are left in Stewart County?
We are the only one.
The last shop in town.
We are the last pharmacy standing.
How many, 21 years ago, how many were there?
So for the most of the time, there have been 3.
Okay.
And they have slowly either been sold or closed.
Yeah.
So, and that 3, it has changed during that time, but all of them eventually sold or closed.
I'm from rural West Tennessee. When I was a kid, there was a hospital in every county, and this past spring, my mom became septic, needed to go to the hospital. Closest one was 55 minutes away now. So it's
yes, very different.
Dramatically different than it was when I was growing up. So you wear a number of hats, and instead of asking you what your favorite hat is, which is truly what I'd love to know, let's talk about how each of the hats are challenging and the ways that they are challenging, and they intersect with each other. So what do you find most challenging about being a community pharmacist and a board member at the same time?
I would say looking at the rules that the board currently has, and then looking at the practice setting and the changes that are occurring in the practice setting. Understanding that the rules process is cumbersome and lengthy, and it is not quickly responsive to the changes. Pharmacy is a very dynamic profession at the moment. There are a lot of changes, and the rules struggle to keep up. There are areas in which the rules were written for a different time and a different service level. There are areas in which there are no rules at all, and we have a need for those rules because of what we are seeing take place. So that is definitely the biggest struggle, is the fact that the rules process is cumbersome and it is not quickly responsive to the changes in the profession.
Do you find it comforting or frustrating in the fact that there's not a rule, there's not a black letter that we can point to for every situation that you encounter in the practice of pharmacy? Do you find that legal knowledge comforting or troubling when there isn't an answer from time to time?
Personally, I find that comforting, and I'll tell you why. Having been trained in both these professions, the training approach is very different, not just in the manner, but in the focus. Healthcare is about individuals. There are not enough algorithms for every individual. The uniqueness of circumstances, I think, demand a certain level of professional judgment that cannot always be written in a rule or a law. And without that, the goal of providing care will not be reached, because you need some flexibility to fit the situation in front of you.
Right.
And rules frequently are rigid.
Fun question time. If I had to tell you right now that you couldn't go back to the pharmacy, you couldn't go back to the board, you couldn't be city judge, couldn't be an attorney, what would you go do?
Well, I'm going to assume that I have established a strong financial position. I wouldn't necessarily say education, but advocacy for changing the healthcare system to address some of the needs that I see, the gaps that I see. So advocacy, just as a citizen, serving in any capacity, whether that's a committee, a board, or just speaking with people who can impact change, that would be an area that I would really like to spend time in. I think it could contribute to a better system and much better outcomes. I don't have all the answers, but the status quo needs to be shaken a little bit.
Yeah.
At our pharmacy, I really look at it as evaluate, educate, and participate. Evaluate the circumstances for that patient, specifically educate them as best you can, and then participate with them in the process as they go forward, hopefully to a good outcome.
Yeah. Before we leave this topic, you said that you had an affinity for substance use, addiction specialization. Walk me through what that concept looks like in your utopian, I don't have to do any of this anymore world. So
I have had that in my family, so it's been up close and personal that seeing that process. Also, as a pharmacist in a community, I see that. I think the opioid crisis escalated it astronomically from when I started 30-something years ago. I have seen how that addiction is not just a disease for the addicted person. The realm of effects go to family, friends, significant others, community, workplace. So the waves of impact are so strong. And we have not approached it head on quickly enough. The resources available, that would be the area that when I said I would spend time would be trying to advocate for more resources or be that resource. In a rural area, resources are extremely scarce.
I mean, beyond.
So that is a passion of mine, is helping these people work through this, because we are losing all of the gifts they have. That we're losing so many wonderful things to this addiction because this person is caught in and paralyzed.
Yeah.
And I feel so sorry for us as society.
So, segueing a little bit from that into community pharmacy, tell me why I can drive to Dover Family Pharmacy in Stewart County, Tennessee, and I can see you. But if I try to do that with my provider, my medical doctor, I'm not going to have the same result. I'm not just going to be able to drive to the doctor's office and see Dr. Smith instantly. Why is that?
Well, I think the origins of the profession play a role in that. Pharmacy has always been very accessible. If you think about it, and I call attention to it frequently, we are the only doctorate level healthcare practitioner that you can walk in and access without an appointment or obstruction. Every day, folks walk into Dover Family Pharmacy right up there, call my name, and we have a conversation. The medical community has become siloed, and I'm not saying that in a negative way, but I think back 30-something years ago, when you wanted treatment, you basically saw your local primary care provider. The silo of specialization is a good thing, but I do think it has been isolating between healthcare providers. How much information is being transmitted directly from the cardiologist to the nephrologist to the oncologist to the orthopedist to the dermatologist? Pharmacy is the center, the intersection of all of those.
You're the only pharmacy in town.
Yes.
How does, and we've hit all around it, so I just want to drill down for a second on the concept of a pharmacy desert and what pharmacists can do, what pharmacies can do. I mean, especially in your community, I'm going to drive by 10 on the way home. It's hard to say that as we sit here on Music Row in Nashville that we're in a desert. But you're going to leave Music Row and go back to Stewart County where you are the only shop in town. What can you do to deliver healthcare to the masses?
Especially since not only are we in an area that has limited pharmacy services, we are also in an area with no urgent care clinic, no hospital in the county, only one physician part-time. We have some mid-levels, but not enough mid-levels to take care of the patients. Frequently, you have a child that you think may have strep when you're told it'll be a week before we can get you in. That really does not help you.
Right.
And many people have said, oh, we would gladly come to the pharmacy if you were able to provide that for us, that test and treatment. Ear infections, poison oak, poison ivy, many conditions that we see frequently, yet they aren't able to get care for in a reasonable manner. And when I say that, taking the day off work to drive 25 to 30 miles to sit 2 hours in an urgent care waiting room with your child is burdensome for anyone, especially a family of limited resources. And some do not even have the resources to do that.
Got it. Where do you see the practice? Where do you see the greatest opportunity to expand the practice?
So you read all of these articles talking about the shortage of primary care providers. And in the past, mid-level providers have stepped in where physicians, many went to specialized practice. Far fewer what we call family physicians, general practitioners today than in the past. Mid-level practitioners fill that role. Now, I see mid-level practitioners exiting for specialty practice. So there are far fewer of those doing acute care or general practice. I feel pharmacy can step into that space and provide some of those services. I'm not saying all of those services, but some of those services.
Gotcha.
And I think that is great for the profession. It's great for the patient, and it fills a dire need. And that really becomes important when an entity involved in payment does not allow that elderly patient to utilize the services of the pharmacy that is there. It is so disheartening when an 80-year-old cries saying, I have to drive 35 miles to get my medicine because my payer will not allow me to get it here, and I want to get it here. I know you. I know the people that work here. You deliver it to me, and I cannot manage mail order. They want me to either drive or do mail order. I can't manage mail order. I cannot work through the phone tree. I cannot understand the people on the other end. They send things that I don't know what it is, that I don't need. They don't send things that I do need. So that is another big gap where I feel the patient needs are not at the center of the scheme. So with many of these payers, these are just adhesion contracts, terms that they determine, terms that obviously are beneficial to them, and it's take it or leave it. Now, many people say leave it. In a community like mine, these payers control payment for large number of people. Are you going to deny service? Are you simply going to say, Ms. Jones, I'm sorry, I cannot service your needs because your payer refuses to negotiate in good faith, and I cannot withstand the terms of their agreement that they have total control over. And that is why you are seeing closures of pharmacies, because if you do not take it, then your market of patients is cut way down. If you take it, many times it is at a loss, a huge loss to you. So destiny says you are not going to survive. I say, and I use them Lowe's. If Lowe's buys a $1,000 riding mower, they do not price it to the public at $1,000.10. It's illogical, and no one would expect a 10-cent profit margin.
Right.
But that is frequently what is happening every day, every single day in my world. Yeah. And sometimes it's $1,000 cost and the reimbursement's $975. You cannot sustain that for very long. And service dries up. And it doesn't matter how good your service is or what your patient population is or how much you go above and beyond. None of those things are considered in the picture. And this is where we must reevaluate that. We cannot allow that to continue, because just like rural hospitals, pharmacies are going in rural areas are going to close. And it's not just going to be rural areas. There are going to be deserts in urban areas. Mm-hmm. And if the nearest pharmacy in an urban area to you is 6 miles away, but you don't have reliable transportation or access, what's the difference in there or the nearest one being 25 miles away?
Walk me through what you go through, new patient, new script, first time you've ever seen it. Walk me through what happens.
So one of the things that I try to educate or communicate to people frequently is what exactly the pharmacy does. A lot of times people believe that it is a very simplistic process, that you throw some pills in a bottle and hand it to them, and that's pretty much all it is. That is far, far, far not the case. So a patient comes in, the first thing we have to do if we've never dealt with them, we have to get some type of information on them. And at a minimum, we need a name, address, birthday, telephone number. But we need to know what medications are you on, what disease states do you have, what drug allergies do you have. And then we would take the prescription that we have for you, and we, as a part of our requirement, we have to look at that to determine, are there any drug allergy contraindications, drug disease contraindications? Are there any drug interactions? Is the prescription appropriate for the diagnosis? Is the therapy the right therapy, the right strength, the right duration? So it is a great deal of things that go on. It is much, and it is getting more and more. And the burden on the pharmacist as the regulator is weighing the profession down.
Very real.
It is, unfortunately, we become a point at which it's like, we need to regulate this. At what point are we going to do it? Oh, the pharmacy will do it.
Yeah.
And I think you understand that. I have yet to hire an employee, other than someone that's been to pharmacy school. Any tech or clerk that I've ever hired after working at the pharmacy for about 3 weeks all say the same thing. I had absolutely no idea that you had to do all this. I cannot believe all of the things that have to happen just so they can get that medication. When I was on the other side of the counter, I wondered, what do you all do there? And now I can't believe that you can accomplish this. I mean, it's almost insurmountable.
Guilty. I started practicing pharmacy law about a decade ago, and when I came into it, I mean, even the joke around the office was, isn't that just a profession where you transfer medications, where you repackage medications? And no, it's such an eye-opening experience to feel that, and how that is an everyday part. That's just not one prescription.
Yeah, every prescription.
You might have to do that 30 times today, 50
Yes.
times today, and that's burdensome. That's tremendously burdensome. It's one of the more difficult professions that I saw at the Department of Health because of all the pressures. There are very few professions, health-related professions, that have a patient pressure. I'm sick, I want my drug. A regulator pressure, why did you dispense that drug? A payer pressure, and then just a general business pressure on top of it. Nobody else has that mixture all at the same time. Let's finish up on that topic. What keeps you awake at night between pharmacy and board activity?
So pharmacy, what keeps me awake is there are forces that are providing obstacles to patient care. And there's a long list of them. Some are natural forces, some are created forces. But I am of the belief that regardless where you live, you deserve to have good care, and you deserve the opportunity to have a role in selecting that care. And there frequently that is not occurring, especially on the selection part. People are being steered here or there, and they're not getting to play that role. I had a patient call and say, well, I have to get my medicine at this pharmacy for my payer, but I called you because y'all are the pharmacy I trust. And I thought about that. It's a sad thing when you cannot utilize the pharmacy that you trust because your payer directs that. So that keeps me up at night, because we could have so much better outcomes, so much better quality of life if we modified just a few things. From a board perspective, the sheer weight of responsibilities that are put on pharmacists, and the fact that with new technology and new service initiatives that have yet to have rules in place, I fear patient harm. I remind people frequently, the medication is not a roll of paper towels. I think patients do not walk in the pharmacy with the feeling that they have to be on guard, that there's going to be harm resulting from that visit.
Yeah.
They walk in feeling confident and that it is going to be beneficial to them. And not just the experience that they have at that moment, but the overall pharmacy process is going to be beneficial to them.
Yeah.
And as a board, I'm thankful that that is the case, and I do not want us to lose that confidence. So navigating some of these things that you mentioned is tricky. It is a fine line as to how far can we go in this area before we need a rule saying, hey, we need a pause, we need to stop, or we simply, with the service that we provide, we simply cannot provide it the same way that the grocery store or the hardware store provides it.
Yeah. Dr. Blane, this has been fun. Thank you so much for joining. Could not be more honored to sit across the table from you. I've enjoyed practicing in front of you and with you in this new role. I'm honored to be here. So,
well, thank you very much. It's a great pleasure for me, and also working with you again, because I had such great respect for your service to the board in your other role, and enjoyed working with you and talking with you about these things. And so I'm glad we're able to continue that relationship.
Yeah, absolutely. Fascinating stuff. Thank you, Dr. Blane.
Thank you.